Good afternoon, everyone. I would like to welcome you all to this symposium on the challenges and innovations in Europe on the fast track to ending AIDS. This session will be co-chaired between myself, Dixon-Williams from the European AIDS Treatment Group, and my colleague, Mr. Martineau, the Director of the Fast Track Implementation Department at UNAIDS. Today, when we listen to our panel's presentations, we must have a clear understanding that these innovations and the agenda must be collaborated with and driven by communities. We must ensure that all key populations, MSN, women, people who use drugs, and trans people of all ethnicities are aware of PrEP and can access PrEP across Europe. We must ensure that we have the data on key and specific populations. Otherwise, we cannot pretend we are responding to the needs of these populations. It is this lack of data is what continuously leaves us behind. We must address the structural barriers on human rights, stigma and discrimination that remains a significant barrier for people to access services. And we must ensure that the message of you equals you is understood across the health arena in Europe and by the public in order to reduce and end stigma against people living with HIV. We must ensure that governments agree to and follow through with funding for the HIV and related co-infections and comorbidities, and that there's a clear accountability about how funding and resources are used. When we talk about not leaving people behind, we must ensure that those who face legal and policy barriers in Europe are reached. We are not hard to reach. We are simply excluded in many environments. And finally, it's imperative that there is a real and meaningful involvement of all of us living with HIV at all levels of the HIV response. We must be involved from the start with funding, planning, implementation, and the evaluations of all policies and programs that affect us. This is the key foundation stone to ending AIDS by 2030. There is nothing for us without us. Thank you. And introducing for the keynote address, I have Mr. Andrew-Kaitis, the Health Commissioner from the European Union. Thank you.
Ladies and gentlemen, HIV/AIDS is a serious disease that continues to impact the lives of millions globally. In 2015, with the Sustainable Development Goals, we made a global commitment to end the AIDS epidemic by 2030. Now we have 2018, 12 years we have in the future. A year later, United Nations member states, including European Union member states, built upon the foundation with fast-track commitments to measure our progress to reduce new HIV infections, reduce AIDS-related deaths, and eliminate HIV-related stigma. AIDS 2018 is an opportunity to reiterate those goals and to reaffirm that commitment. I am honored to be part of this important event. And I want to thank the City of Amsterdam and the Ministers of Health and Foreign Affairs of the Netherlands for organizing and hosting. The focus today is on HIV and AIDS, but it is also about so much, about tuberculosis and hepatitis and other communicable diseases. It is about vaccination and poverty, stigma, social exclusion, education, human rights and justice, clean water and sustainable consumption too. This is not just about health. And it is not just the responsibility of health ministers and health organizations. Global health is everyone's concern. The SDGs position health as a determinant, outcome, and indicator for sustainable development, and success requires unprecedented collaboration between governments and across ministries and sectors, local communities, and so on and so on. We are making progress on health and many other parts of the 2030 agenda, but that deadline is getting closer. We need to accelerate our efforts and ramp up our collective partnerships. Now, allow me to say a few words about Europe and AIDS. The 1990 treatment targets have set out clear goals for 2020, and with sustained efforts, members of the EU and the European Economic Area are on track to meet these goals. The latest data from the European Centre on Disease Prevention and Control shows that 86% of all people living with HIV were diagnosed, and it's okay. 90% of all people diagnosed were receiving treatment. It's good. And 91% of all people diagnosed and on treatment were virally suppressed. More than 800,000 people were living with HIV in the EU and the European Economic Area in 2015, and about 15 of these, or 120,000 people, had not yet been diagnosed. We need to focus our efforts on these undiagnosed individuals. I should stress that some countries are still facing challenges in meeting the 90 targets. But progress is in testing and diagnosis, and the improved linkage to care that can be witnessed across member states brings Europe closer to the triple 90 targets. On the other hand, a sharp reversal is needed if the broader European region is to meet the 2030 targets. And I am especially concerned about the growing epidemic in our eastern neighborhood, where we need sustained efforts. The European Commission is determined to support member states and neighboring countries in this regard. I am proud to inform you that we have just published a Commission staff working document on combating HIV, AIDS, viral hepatitis and tuberculosis in the European Union and neighboring countries. The document builds on the 2016 Commission communication on next steps for a sustainable European future. It aims to provide decision makers, stakeholders and citizens with an overview of effective policies in the prevention, control and treatment of HIV, AIDS, viral hepatitis and tuberculosis. Across the globe, those three epidemics pose the greatest risk to groups that are often subject to discrimination and stigmatization, and it is very painful. Of course, we know all very well about prisoners injecting drug users, the homeless, sex workers, as well as men who have sex with men, migrants and refugees, are all more vulnerable to infections. And a growing body of research suggests that HIV-related stigma is a major obstacle to seeking, accessing, or staying on treatment. Understanding the stigma and reducing it should be a key priority in the months and years ahead. Some of these groups are socially marginalized and have little or no access to preventive and care services. Vulnerable groups are also more prone to multiply health concerns. A recent study showed how women who suffered the war in northern Uganda are almost twice as likely to be living with HIV as men, and are far more affected by trauma and depression. These are complex challenges, and there is no one-size-fits-all solution. Each situation requires a thorough, targeted analysis involving all stakeholders in preventive and treatment measures. EU projects have focused on supporting early diagnosis and promoting testing and greater outreach to vulnerable groups. But we need to do more around prevention, which is by far the most effective approach. Such mantra, prevention, 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 promotion, promotion, protection, such mantra is very important for all of us. And for example, we must ensure continuum of care, from testing and follow-up of early diagnosis to linkage to care, treatment and retention into care. The HepCare project, which provides an integrated care model for hepatitis C treatment, is an excellent example of this. We also need to improve coordination across institutions and administration involved in outreach to vulnerable groups. Portugal, for example, has combined a focus on fundamental rights with changes to extant legislation. Together, these efforts have improved access for the most vulnerable social groups to prevention packages, including early diagnosis, treatment, and harm reduction measures. Outreach to persons at risk should come from primary healthcare settings, but also community health services, including homeless hosting wards, prisons, and safe injecting houses, social workers, and peer support groups. The EU pleads also in international fora for a proportional sentencing and alternative measures to incarceration for those having committed minor non-violent drug-related offenses. The Abrigado Safe House for Drug Injections in Luxembourg has significantly reduced drug-related harm and offers a model that I would like to see replicate elsewhere. Innovative approaches like community-based testing, self-testing, and home sampling should also be reinforced. But 2 out of the 3 countries in the EU and European Economic Area claim not to have sufficient funds for prevention measures. Adequate funding and research are key components of meaningful interventions. So allow me to briefly mention some of Commission's funding initiatives in this field. First, we have contributed more than 1.8 billion euros to the Global Fund since 2002. And more than half of the overall resources of the Global Fund were spent on HIV control measures. Second, Horizon 2020, the Programme for Research and Innovation, has committed over 115 million euros to HIV/AIDS research. The new Horizon Europe program will continue building on the achievements of previous programs and contribute to boosting the scientific, economic, and societal impact of EU research on HIV/AIDS, viral hepatitis, and tuberculosis. And third, more than 70 initiatives, including projects and joint actions related to diseases such as HIV, TB, and malaria, have been funded under the EU's health program since 2003, with a total investment of 46 million euros. In fact, we have a stand which provides further information on the EU actions in this field, which I invite you to visit. And fourth, in 2017, the Commission called for research to addressing the growing HIV, TB, and viral hepatitis epidemics in Eastern Europe. The European and developing countries clinical trial partnership, launched in 2003, fights poverty-related and neglected infectious diseases and supports clinical trials and capacity buildings in Africa. So the European Commission is approaching these epidemics from all angles: funding, research, prevention, treatment, and education. And we look to take a collaborative approach at all times. We need to address these 3 diseases together if we are to meet our sustainable development targets. As Commissioner for Health and Food Safety, and as a doctor, I am determined to work with all stakeholders, and I am fully committed to supporting Member States and neighboring countries' actions to eliminate these epidemics. The EU HIV, AIDS, hepatitis, and tuberculosis think tank is an important forum in this regard, in that it facilitates the exchange of information and strengthens cooperation between EU member states and neighboring countries. Direct engagement with civil society organizations is crucial too, and I am thankful the EU Civil Society Forum enables this coordination. We have recently expanded the scope of this forum to include hepatitis and tuberculosis, reflecting their positions in Goal 3.3 of the SDGs. But as I said earlier, this is not just about AIDS, and it is not just about health. The SDGs are interconnected. The success of Goal 15 depends on the success of Goal 12. Both are dependent on goal 13. Some of the goals have a very direct link with AIDS and others less so, but they are all co-dependent. And they are all reliant on coherence and coordination between ministries, governments, all sectors, local communities, and societies. So I urge you all to prioritize effective collaboration as we strive to meet these goals. Finally, I want to recognize the leadership shown by health professionals, community partners, and most importantly, by those living with HIV/AIDS. I salute your commitment and your contribution, and I look forward to working with you to meet the 2030 agenda. We have only 12 years to implement, only 12 years, because we know very well to leave no one behind. 12 years we are in our hands, we have in our hands, and let's do our best. Thank you.
Thank you very much, Commissioner. It's good to hear the significant range and breadth of the work of the Commission, and I'm sure there'll be lots of questions coming later when we come back to that part of the agenda. I'm delighted to have to chair this next session. We've got some really great speakers just to talk around different perspectives of the response, both internationally and within the context of Eastern Europe and Western Europe. And just to summarise briefly here, we have Minister Agnès Buzyn, who's the Minister of Health from France, and she's going to speak to us about the French response, the priorities that they have, their approach to leaving no one behind, and some of the successes and challenges that she's seen in the response and what needs to happen into the future. That's going to be followed by Michel Sidibe, who's the Executive Director of UNAIDS. And he's going to be talking about the importance, the continuing importance of the European Union, both in terms of taking forward the response and providing leadership, both within the context of countries of the region, but also within the context of the global response. I'm pleased to say we've got two civil society perspectives. The first is Ferenc Bazinski from AIDS Action Group. And obviously he wants to talk a little bit about the rising epidemic in southeastern Europe and obviously the relationship that has with Western and Central Europe. Mark Biot from MSF Belgium, talking about some of the issues as he sees it within the context of Western Europe around human rights, HIV, and particularly around the issues of migrants. And then we'll close the session with now I'm going to be careful here. Jose Manchanden, she's the Director for the Municipal Health Service of Amsterdam. And obviously the City of Amsterdam's been really out there in the lead in terms of the fast-track cities approach and talking about some of the experience that they've had and some of the learnings and relevance to what we're trying to do within the context of Western Europe. So without further ado, I'll ask the Minister to come up, please, and speak. Thank you. Do you want to stay there? It's up to you, whatever you prefer.
Tu fais comme tu veux. Je crois que c'est mieux que tu ailles là-bas.
If you prefer.
That's okay.
Thank you. Thank you very much, ladies and gentlemen. It's a pleasure to be with you today. Allowing everyone to live in good health and promoting well-being for all, at all ages, is at the heart of the French National Health Strategy. And of course, HIV control is fully embedded into this strategy. As a Minister for Solidarities and Health in France, I'm committed to translating this goal into reality in the daily lives of all French citizens, and especially of the most vulnerable ones, as quickly as possible. But we need a paradigm shift. Our health system needs to evolve. Relying mainly on curative care is no longer possible. That's why France has decided to shift towards prevention. As you know, 35 years after the discovery of the AIDS virus, researchers from all over the world are committed to develop prevention strategies and that could stop new infections, such as vaccine, as well as innovative therapeutic approaches to achieve remission. But we need to promote a strong message on evidence-based and combination prevention. We need to hammer again and again the importance of condoms, particularly among young people, those who did not live the dark years of the epidemic. They are largely unaware of how HIV is transmitted, and sometimes they think that AIDS is a standard chronic disease. We also need to support pre-exposure prophylaxis, PrEP, and act for its adoption among the key population. France was the first country in Europe that covered 100% of its cost without waiting for marketing authorization. And PrEP is also a step towards testing HIV as well as other STIs and towards comprehensive care. We need to ensure fast and benevolent access to post-exposure treatment. We need to increase awareness and knowledge on the treatment as a means of prevention, now conceptualized by the actors under the term of undetectable equals untransmittable. Of course, we also face a major screening challenge to reduce the hidden epidemic and allow patient care as early as possible. We also have the HIV self-testing tool available in pharmacies now and in France, and free of charge in screening centers and in associations. With all these tools, the main challenge today is to continue our actions, but also constantly re-examine our strategies to make them ever more effective. We need to work against social and territorial inequalities of access to health care, which are a reality in every country. We must ensure equal rights for all in the area of sexual health and respond to the specific needs of the most vulnerable populations and those most at risk of HIV. And our actions must reach those populations most exposed to sexual violence, HIV, STI, and viral hepatitis. I'm thinking of women, of gay men, young men who have sex with men, trans people, lesbians, people with prostitution, people in prison, drug users, and migrants. So these are the population we now have to focus on. We need to change social representations related to gender identity, sexual orientation, age, or disability, as well as for people living with HIV. To respond to these issues, we are engaging right now in France a comprehensive approach for sexual and reproductive health, aiming in particular in guaranteeing to each individual a safe, autonomous, and fulfilling sexual life. France is also very involved in the international level to reach our collective goal by 2030. As you all know, for more than 30 years, France has made the fight against the major pandemics, and more particularly against HIV/AIDS, one of the top priorities in global health. Our commitment was translated in many participations in the Global Fund, UNITAID, as well as WHO. This involvement, along with the efforts dedicated to research through our national agencies such as INRS, INSERM, and other research organizations, has made France at the top level of the fight against HIV. And this commitment had been reaffirmed by our President, Emmanuel Macron, through his decision to host in 2019 the 6th replenishment conference of the Global Fund for the period 2020-2022. France has participated to the creation of the Global Fund and is the second largest historical contributor with more than 4.2 billion euros since 2002. And because we really want to ensure that fight against HIV is at the top level of the global health, we will be completely dedicated to this replenishment conference. I am, like you and other political decision makers, concerned about our ability to achieve the goals which were reminded by the Commissioner. We are all convinced that the fight against HIV is a new step, it needs a new step. We need other prevention tools, obviously to intensify the search for a vaccine, but also to include this fight in a global effort to reduce co-infections, other causes of morbidity, the weight of chronic non-communicable disease, in a prospect of improving the health of populations. I want to thank you for your attention. Thank you again.
Okay. Thank you very much, Minister. I'm going to turn now to Michelle to speak. I would want to just, I know Esther wanted to make a particular comment about this, but to really thank France for taking on the Global Fund replenishment as a really important commitment. And I'm sure everybody's going to work to support that as much as we can. Thank you.
Thank you very much. Let me just say again, that is the beauty of AIDS conference, to have people who can come and echo their voice. Your welcome is very important. It is important for us to be back here in Amsterdam after so many years. And I want to thank the Commissioner for really bringing this powerful panel together. From Europe. It's important because I personally feel is topical. People feel sometimes that when we are talking about this epidemic, we are talking about a different world. We are talking about Europe in one side, US in one side, Asia in one side, Africa in one side. I think in reality what I saw is a global solidarity with a shared responsibility. That's what helped us to be where we are today. I want to thank all of you, particularly European countries, because it's about Europe, for helping us in three ways. First, you have been a great international donors. People can accept without any doubt that collectively European member states provide the largest, I said the largest share of international funding for AIDS response. France is hosting the Global Fund replenishment for in 2019. And I think it's a great decision from the President Macron in a critical moment where we are all seeing, unfortunately, that funding is almost stagnating, and we are flattening the levels, and we are seeing even decline. And it's very important at this moment to see this commitment coming from Europe. And Europe has been also innovators in many sense. In terms of bringing new medicine, in terms of demonstrating clearly that we can go to scale. France pushed us when they were saying those days that medicine is in the north, but people who are suffering is in the south. That has been a major call, activist call, to help us to transform this fight against the epidemic. Portugal has been demonstrating that we can, the Commissioner was talking about it, that we can decriminalize the drug use, that we should not be scared of that one, that by decriminalizing, they didn't see an increase of drug use, they didn't see the whole risk we are facing when we are punishing people. So London has been able to demonstrate that we can reduce by 40% the infection, new infection among a key population by just introducing the PrEP. The response in Poland is certainly one of the most advanced in Eastern Europe and Central Asia. So I want to say that you have been also a broker of a political engagement. And that is very important in this response, ensuring human rights, demonstrating that it's very important to have a gender-sensitive based approaches. And the role of your countries like Germany pushing for rethinking the global health architecture, Sweden also. I think it's all those countries who have been coming together to really push the agenda. Today, following your presentation, I want just to say that it's very good because it is in line with our report, new report. What you have been showing, Commissioner, is that we still have gap. And those gaps, we need to fill it. It's, of course, 90 or achieved in most of the countries. But unless we reach those 10% remaining, the hardest to be reached, we will not be able to control the epidemic. And to do that one, I want to say really that we need to fight the new conspiracy which is emerging, which is complacency. And that we are seeing that amongst our young gay in Europe. We are seeing a growing epidemic amongst them. And we need also to address a new emerging issues, which is the migrant population. We cannot really close our eyes and say that, oh, what we do, we need to have a cross-border policies. We need to think about really life of those migrants and how we really come out with policies which could be inclusive. We have sex workers. We need to have a protective laws. I know that Madame Buzyn, the Minister of France, is completely thinking, and she has certainly the same understanding on many of the issues you're raising. But we need to establish a dialogue. We need to make sure that this dialogue could be happening to help a sex worker, transgender people, prisoner. All those are the right of people, and we know that their right should not be something we will negotiate. It needs to be respected. It needs to be put in place. And finally, I want to say, please help us. Make sure that we don't face this cut of resources. Because if we have any cut, I can tell you, even small cut, we have a modeling showing that 20% reduction will have a catastrophic impact on 44 countries today in the world. And when I said catastrophic impact, I'm very serious. 20% cut, for example, in Mozambique means for Mozambique government to double their health budget to be able only to finance their HIV/AIDS programs. So it's very important for us that you continue to advocate under the framework of SDG, like you rightly said, to make sure that AIDS response continue. We are not yet there. We can win against this epidemic. Europe can be the first part to demonstrate that we end completely this epidemic as a public health threat. But we are not there. We need to really continue to advocate, and I hope this conversation does not stop here, and that we will be able, under your leadership, to really make sure that you put HIV on the agenda of the European Council of Ministers of Health. Together we can end AIDS, and I am so proud that we are back in Amsterdam, and I'm proud to be part of this meeting today because Europe is critical in many sense for ending disease and contributing to really reduce poverty and reduce inequities in the world. Thank you very much.
Thank you, Michelle. So it's on the UNAIDS board, we have civil society participants, and the last time I saw Ferenc, he was giving us a tough time at our board meeting. So it's nice to have him here and coming to talk about Eastern Europe and where he sees the world there. So Ferenc, please come.
Thank you, Tim, and sorry for giving you a hard time, but I'm going to talk about Central Europe and Southeast Europe, not Eastern Europe. Good afternoon, ladies and gentlemen, friends and colleagues. Thank you for the introduction, and I would also really like to extend my special thanks for the organizers of this symposium to include the topic on the agenda. It is very rare that there's an opportunity to talk about epidemic among gay men and other MSM in Central European and Southeast European countries. I have been working on the issue of HIV in the NGO sector for over 10 years now. And the very first international meeting I attended was in May 2008 in a picturesque, lovely town of Bled in Slovenia. The meeting was a technical meeting on HIV/AIDS in Europe, and it was organized under the EU presidency, the Slovenian EU presidency. After the meeting, representatives of civil society, organizations and networks, we came together and we created the Ljubljana Declaration. Ljubljana is the capital of Slovenia. The declaration was to warn all stakeholders that HIV remains a most alarming health threat among gay men and other MSM across the European region, and B, to make a series of suggestions how to improve gay sexual health and well-being. We are in 2018. It is 10 years after the declaration. Since then, we have learned so much. We know now that treatment works as prevention. We also know that PrEP is very effective in preventing the sexual transmission of HIV. We know from experience that community-based rapid testing services and self-testing kits are crucial in reaching those who are not reached by the public health sector. We know what works. And we see results of these inventions and interventions. We see incidents dropping in cities like London, New York, San Francisco. Elsewhere we are not. Elsewhere we are not benefiting from these innovative approaches. Our fundamental rights, our right to health and our right to prevention, I like to include the right to prevention as our fundamental right, is being ignored or abused. We are being left behind. The elsewhere today I'm going to talk about are the 19 countries in Central and Southeast Europe, and allow me to name them one by one because there is a high chance that this is the only time that you are going to hear about these countries at this conference. So there are Bulgaria, the Czech Republic, Croatia, Cyprus, Estonia, Hungary, Latvia, Lithuania, Malta, Poland, Romania, Slovakia and Slovenia, EU member states, and 6 EU enlargement countries, Albania, Bosnia and Herzegovina, Macedonia, Montenegro, Serbia and Turkey. These countries have long been referred to, and are still usually referred to as low prevalence countries. It is the low prevalence region, but we communities from the region, I'm Hungarian by the way, we know that from experience that low prevalence equals to low or little attention, both at the international and also at the national level. Although the region is very diverse, we are talking about 19 countries, so there is a saying in Hungarian that if it's not your shirt, don't put it on. So if it doesn't refer to your country, then please don't be offended. But there are some common features which that indicate that this region is clearly left behind in the global response. The notion of low prevalence is used by local and national governments to delay or block the introduction of new prevention methods, just as in France PrEP was introduced. There are discussions about it in our region, but there's little or any progress. The notion of low prevalence is also used to provide little or no funding for NGOs working with key populations and ignore the needs of communities most affected by HIV. There is also a phenomenon of conservatism and the trend of scapegoating certain populations as part of populism that is fueling stigma and discrimination against key populations such as sex workers, migrants, or gay men and other MSM. And I lost my paper. Oh, it's here. International funding mechanisms, the Global Fund, the Joint Program, etc., have either never been present in these countries or have already left or are leaving the region and leaving a void in funding for communities and civil society organizations, and this void is not filled up by the government, but by domestic funding. And those few international donors that are still trying to support civil society in the region are being demonized as foreign influence and used in national election campaigns, just like it was used in spring in Hungary in the general election campaigns, where the Soros Foundation was the demon that was trying to influence and change politics within the national politics within the country. NGOs are facing hostile and suffering hostile social and legal environments, being labeled as agents of foreign interest. The UN Joint Program on HIV/AIDS, so UNAIDS in short, but it's a lot of agencies together, are also unfortunately not really present in the region. And the funding from the health program of the European Union is very difficult for us, civil society from the region, to access. And that's because partly due of lack of capacities, but also because sometimes participation is decided by the governments, and the governments are not nominating or not participating in the programs, or they are nominating the wrong NGOs. This neglect has resulted in a 300% increase in new HIV infections among gay men and other MSM in the past 10 years. That's tripling the numbers in 10 years. That's really bad. We still might be talking about relatively small numbers that disappear among the millions that are reported globally. But looking at the trend, a 300% increase in 10 years is a clear sign of neglect. As the world is on the fast track on reaching the 90-90-90 targets, and it was really nice to see that the European Union is very close to reaching the 90-90-90 targets. But if you look at the country data, you disaggregate the rate data, you will see that the east of the European Union is not there, very far away from there. So as we are reaching the 90-90 targets and we are working on ending AIDS by 2030, we communities from all over the world are seeing that we are being left behind. When looking at global figures and reports on progress, these regions, these communities disappear in the numbers because there's small numbers, so they don't show up. You really need to look for them. And if you look, you will find us, the 10-10-10. If you disaggregate the data, you will see that in the 10% undiagnosed, 10% not accessing medication, and 10% not having a suppressed viral load, there are certain key populations in certain regions, including Central European gay men and MSM. Now, 10 years after the Ljubljana Declaration, representatives of national and regional HIV and LGBTI networks and organizations, we came together and published our urgent call for action. It's the Ljubljana 2.0 Declaration. We call our governments to honor their international commitments and upon EU member states to meet their obligations to respect the fundamental values of EU. We call upon the European Union and its institutions to recognize and address the situation of expanding HIV epidemics among gay men and other men who have sex with men in 19 newer EU member states and the candidate countries as an urgent priority. And finally, we are calling upon international organizations, including UNAIDS and WHO, to reinforce advocacy and efforts to build political commitment for scaling up responses to the rapidly expanding epidemics and to intensify efforts towards ensuring the enjoyment of the highest attainable standards of health for LGBTI people everywhere. And I'm about to reach the end of my speech. I must share something with you, and that is speaking in public is way outside my comfort zone. For me, speaking in public equals anxiety. But I'm wearing this T-shirt because being silent equals death. But as we know from the HIV movement, we cannot stay silent. We all must step out of our comfort zone, governments, EU, and institutions. And we must draw the attention to the fact that currently communities and regions, such as gay men and MSM, in Central and Southeast European countries are being left behind in the HIV response all over the world. And this needs urgent attention, funding and interventions if we are to take our commitment, targets and goals to end AIDS by 2030 seriously. Thank you for your attention.
Thank you very much, Ferenc. I'm going to move now without any further introduction. I don't think MSF needs much of an introduction. Please, Mark, come and give us your thoughts. Thank you very much. No, I don't know how this is going to work.
Thank you. And then, that must be it. There we go. Ladies and gentlemen, let me share with you some reflections, some witnessing, some témoignages from our MSF teams throughout the world, but mainly also based in Europe, with a migrant's perspective on what they face when they arrive in Europe. The objective to have a safe and responsible migration and mobility through sound and well-managed migration policies is undoubtedly fundamental. Reality, however, is that current policies are more restrictive than ever, impacting health and well-being of migrants and refugees fleeing conflict, oppression, and also economic hardships of their home countries. Through our past and present operations in Europe, in Southeast Asia and Southern Africa with migrant populations, MSF has witnessed significant medical and humanitarian consequences of restrictive migration policies, with evidence of ill treatment and abuse, violence up to sexual violence, and also living conditions which are far below international standards. It would be no surprise to anyone that the current vision of some member states to criminalize migration leads to increasing health and humanitarian needs, and I will quickly bounce on that back in the next slides. It forces people to irregularity and prevents them to access health care that they need for their present needs. It also, unfortunately, impacts perversely free movement of people also in other regions, like in the SADC region or ECOWAS, who either are put under pressure by Europe to decrease their internal mobilities and break, as such, the movement of migration towards Europe, either to follow Europe and copy-paste restrictive migration policies, and by this dropping or putting aside their own legal commitments and legal engagements towards migration population. I will very quickly browse, because I think I'm quite sure most of you know the risks due to mobility that many of these people face. I will not speak too much about the travel and detention conditions, but I think you all have in mind the shallow boats through the Mediterranean, the trucks where people hide for days, and also basically the overcrowded detention sites in Greek islands, where some people can stay for months or years. Overcrowding makes me thinking about the situation we also met in Malawi, where tuberculosis raised by 8 times when we faced an overcrowding of 300% of the inmates in a Malawian prison. Abuse during or even during the travel, and also when they reach the safe Europe haven. Limited access to health care causes interruptions and delayed start of treatment. The stigma impacts their health-seeking behavior. Language barriers exist. People are afraid of the legal strings when they present to a clinic. A lack of harmonized treatment regimens and protocols. This was a reality in Southern Africa until the year 2010, but then thanks to a fixed dose combination, tenofovir-based, we have been able to have the same treatment everywhere. In Europe, we still face individual treatment, not fixed dose combinations. Illegality brings people to high-risk sexual behaviors, and people who are forced against their will to return will be so without any attention to their health needs, and it interrupts usually chronic treatments. The European Convention on Human Rights, though, in its Article 3, asks to restrain from expulsion ill migrants if this would amount to an inhuman and degrading treatment, as follow-up.
However, what is inhuman and degrading treatment? Recently, a lot of restrictions have been seen by laws from countries, EU countries, where people were expelled against appalling clinical or health conditions. A lot more countries in the last years are signing in HIV-related restrictions on entry, residence, or stay. Confusion exists whenever somebody wants to look, is this treatment really available in a country? What is availability and what is accessibility? It might be available for the happy fews in the capital, but what about the province where people can't access it? And also linking a health status when they are looked for screening at entry in Europe might also push the people to distrust a health system because they don't know what the data will be used for. To end, let me share with you some basic data that we've gathered in 2017 together with the London School, with MSF and with Epicentre, when we were working in Samos and Lesbos, two known small Greek islands in the Mediterranean. 70 to 80% of mental health assessments showed or proved positive for an anxiety disorder. However, less than 15% of these were identified by the official system as vulnerable, and less than 30% of victims of torture were identified as vulnerable. 19% out of a sample of 59 people reported experienced sexual violence. However, PEP was only provided after a legal inquiry and was not seen as a medical emergency, and it was mainly due for staff reasons. Access to appropriate medicine for those who suffered chronic treatments on sites varied between nearly 40% to 83%. So this can be found in a much wider, of course, information on the study by Epicentre, London School and MSF, and also in some other reports that we made and that can be available on the web when showing the dramatic deterioration of health systems for asylum seekers in Lesbos, confronting mental health issues also in Samos and Lesbos, also how unaccompanied migrants, children and young people are repeatedly abused. As a conclusion, unfortunately, my conclusion is not a positive message for the moment. And yes, indeed, we have still 12 years to go. And I hope that in these 12 years we will be able to act on what we see every day. Europe is blind on the health needs of its migrants. Security prevails everywhere. Restrictive policies increase health risks. And I'm afraid European migration policies are a source of new HIV infections. Would there anywhere be a need for an independent database on looking at availability and accessibility for treatments, be it mainly managed by civil society, giving accurate information from home countries and civil society in Europe, so that an independent eye can look at what the reality is on the field? I thank you very much for your attention.
Okay, thank you very much, Mark, for that. I know we're running late, so we're going to just change the order a little bit. We've got some rather busy ministers on the panel here. So I'm going to, if Jose's been nice enough to wait and speak in the second panel, so we'll be asking Sabine Weiss, who is the Vice Minister of Health from Germany, to come and speak, and she'll speak a little bit about some of the issues around HIV integration and particularly around TB and the national health agenda. So, the Minister, thank you.
Mr. Andriukaitis, Mr. CDB, colleagues, ladies and gentlemen, in 2015, our governments adopted the Agenda 2030 for Sustainable Development. Within the SDGs, HIV remains an important topic that has been put in a broader context with other infectious diseases. In line with this comprehensive approach, the German government adopted its integrated strategy for HIV, hepatitis B and C, and other sexually transmitted infections in 2016. This strategy takes account of similar modes of transmission and risk factors, but also the stigma and discrimination. The rate of new HIV infections in Germany remains stable at a low level, with about 3,000 new HIV infections each year. But yet the number of new diagnoses of STIs, such as syphilis, is on the rise, and some STIs are widely spread in the German population, for example, chlamydia. With our new integrated approach, we want to take account of the unequal spread of these infections among certain populations and in certain regions in Germany. By pooling resources, we aim at providing person-centered and holistic prevention and care interventions for people in need without leaving anyone behind. As part of the strategy, we defined both national and international fields of action, and in these fields we work towards an open environment without discrimination and with equal access to comprehensive prevention, testing and care services for everyone. In order to promote cross-sectoral networking and collaboration, we set up a new coordinating body. In this body, we bring together partners from both the national and subnational levels, from various medical fields, from prevention and care services, governmental and non-governmental organizations, as well as community representatives. The body gathered twice a year and is the first committee in which HIV, hepatitis and STI professionals are brought together at one table. Besides the regular surveillance, the Federal Ministry of Health has also allocated resources to further collect information on topics such as key populations and co-infections. This data allows us to refine and adapt demand-oriented prevention, testing and care services. Based on these surveys, we adjusted and initiated activities to provide improved and tailor-made integrated approaches. This means, on the one hand, integrated approaches with regard to the range of relevant infection, but also as regards the range and continuum of services. One example of a comprehensive integrated approach are services for people who inject drugs. They are the population most affected by hepatitis C in Germany and heavily affected by HIV and hepatitis B. We therefore support projects to advance the coverage of hepatitis B, C and HIV, prevention, vaccination, testing and treatments for people who inject drugs outside and inside of prisons. Special attention also focuses on men who have sex with men. They are the group most affected by HIV and heavily affected by other STIs and hepatitis C. Several projects are underway to improve and expand relevant severe service offers. PrEP is available in Germany at one's own cost for price of 50 to 70 euros per month. About 6,000 people are currently on PrEP. Taking into account experiences from other countries, such as France, the Federal Ministry of Health last week presented a bill to have these costs covered by the statutory health insurance. We hope that the bill will have passed the German Parliament until the end of the year, and I think the bill will greatly contribute to make sure that people in need of PrEP can afford it. It will also ensure that PrEP users get regularly tested for STIs. In order to increase the number of people who know their HIV status and to reduce late diagnosis, we initiated a law review process. Our aim is to allow the delivery of HIV self-testing kits to laypersons in Germany. In addition, home collection testing will be rolled out soon as well. By expanding these services, we hope to reduce our infection rates in Germany, and together with all European partners, we have to significantly reduce the rates of new infections in Europe and to come closer to fulfilling our triple 95 goal. Integrated approaches also translate into focused efforts. One example are young girls and boys in Germany. In order to improve their STI knowledge and to increase the uptake of services, we have developed tailor-made information material on chlamydia and HPV. The material is directed at medical doctors and patients alike in order to increase awareness and testing for chlamydia and to increase vaccination rates of HPV. All these few examples show we believe that an integrated approach creates an added value for the individual and for society. In this context, mutual learning is vital. Therefore, I would like to warmly thank the organizers of this conference, a conference where people can come together to share their knowledge and experience. And we also thank for the support and coordination of the international partners such as UNAIDS, WHO, ECDC, EMCDDA, and the European Commission. Their support fosters our joint efforts to work towards realizing the SDGs and ending AIDS by 2030. Thanks for attention.
Okay, thank you very much, Mrs. Weiss, and a warm welcome to all the panelists and Mrs. Weiss and Mr. Kroll to your first International AIDS Conference. So we will continue with the panelists, and the next is Ms. Manchanden, the Director of the Health Service in Amsterdam, who will be talking about the leadership of cities and the fast track to ending AIDS and the experience of Amsterdam. Thank you.
Let me see. Let me see how I can somebody help me with the slides? I just have to, like this? Oh, can you help me with the slides? I think the fast track city ones. No, I don't know. Amsterdam? No, maybe this one. I try this one. I'm not sure. It's a good one. Yeah, seems familiar. Thank you. Thank you. Good afternoon. I hope you can take one more lecture. I'd like to tell you something more about the Fast Track Cities program, which Amsterdam is one of the cities. Well, let's face it, most problems show up in the cities. In the cities, the most rich people live, but also the most vulnerable people. And we have to help them. And as cities, we can learn from each other and work together. And I think it's a very nice network we're working on. So I'd like to show you something about what Amsterdam is doing but to reach our goals of 0 infections in Amsterdam. I got a few slides, but I have to pass on quite quickly because of the time. But one thing which Amsterdam does was we started early and we started pragmatic. I think that's really one of the key things of our approach in the Netherlands. We are rather pragmatic. So even from the early 80s, we were working on harm reduction programs for sex workers and people who were using drugs. And those programs, including the harm reduction programs, including access to education programs, healthcare services, services like providing of condoms and clean needles. And here it shows a bus which was providing those services in front of the Dam Square of the palace. And so decriminalization of drug users and sex workers is part of the program. It's very important. We also, you need a sense of urgency. We started quite early. Here you see the Council of Amsterdam in 1983 was very worried about the epidemic coming up. So they asked us to collaborate. All the people working in the AIDS prevention and care work closely together. That was their appeal to all the people, and so we try, and we did. So collaboration and harm reduction were important key elements for our approach. But another one is inclusiveness. An inclusive climate for all people living in the city is very important. And here are some pictures of our Eva Pride, a canal parade, which will be on the 4th of August this year. I hope you can stay that long in Amsterdam, so you can see it. But it's really an important part of our strategy to show, to decriminalize marginalized groups, but especially to support them, to show out in the open, come up, make a boat, join our canal parade, and let's see that we all have worked together and that we all need together to get some goals and to work together and to help each other. You see here the mayor of Amsterdam, the former mayor of Amsterdam, is on the boat in the canal parade as well, and I'm sure that our new mayor will come this time on the boat parade as well. And here you see the policemen. These are not only policemen from Amsterdam, but they are policemen from all over the country who show their support to men having sex with men. They show their support to sex workers, etc., etc. It's very important that we have an inclusive society. This is our gay NGO, or NGO of gay rights, the CUC. They have their boat by themselves. And here's another picture of, we have a big Moroccan migrant population in the Netherlands and especially in Amsterdam. And they have also their own boat in the canal parade. So everybody can see, let's work out together. And here are the rainbow colors as well, showing the involvement of the city in combating the stigmas. And also during this conference, you can see the pictures here in front of the RAI, but also in front of the Rijksmuseum. It's very important for us to combat stigmas and let everybody come out, and there will be help and care for everybody. That's very, very important. So for that reason, also political commitment is very important. And it helps enormously if the politicians stand up and spread the message, no stigma, we will help everybody. Another important part of our approach in combating in reaching our goals is an HIV-related healthcare and an integrated healthcare system. And it's very, very important that healthcare is accessible for everybody. And I'm very proud of the Netherlands that we have a healthcare system which is inclusive for everybody. Our healthcare, every citizen of the Netherlands is obliged to have a healthcare insurance. It's not allowed that you don't have any, but at the same time, all healthcare companies, they are not allowed to deny anybody or to say no to. So they have to accept everybody who apply for a healthcare insurance. But I think it's really very important for our approach. And our healthcare system is also including testing for groups, testing for group at risk of contracting HIV. They also cover treatment, and all those things are very important. And like you heard maybe before this week, from next year on, it will also include PrEP, availability for healthcare systems, for groups at risk, I have to say. It's not officially a part of our healthcare system yet, but we're working on that following Paris, and, but it will become available for risk groups. A bit more to the figures. Figures or data are also very, very big part of our work on combating and reaching our goals and on combating the virus. Good data, a data-driven approach is very, very important. Here you can see that the spread of the virus is very, very divided in different suburbs. In the center, there's much more HIV than in the parts around. So that's really something special. Where are we now? We're talking about the 90-90-90 goals, and here you can see from our data where we are now. For the diagnosed people, we've reached 94%. For the people on treatment, they are 93%, and at least the virally suppressed is 95%. So we are already reached our 90-90-90 goals, but for us it's not enough. We are reaching out for 2030 to have no more infections at all. So that will be our next goal. And that needs a lot of work to be done. And of course, we cannot do it as a city alone. We have to collaborate with all the other healthcare providers and all the other the groups and the NGOs in our society who can all help together. We have to reach out for certain groups, and especially the last percentages are the most hardest to find everybody and to include everybody in our healthcare system. So we have to cooperate with all the people together and all the organizations together. And here you can see, so Joep Lange is one of the persons who bring those H team together. So everybody has to work together in Amsterdam to work on the goals for no infections more in Amsterdam in 2030. So finally, I go on to our lessons learned from the last 25 years, even more, 35 years working on stop HIV/AIDS virus in Amsterdam. First of all, closely working together with all the stakeholders in the work. It's very, very important to meet the challenges together. Identify gaps in the people who we don't reach and look out for NGOs who can help us to get all those people together. Harm reduction, I told you in the beginning, is very, very is very important. Be pragmatic, more pragmatic than idealistic. I think that's very important. Work on an integrative approach in healthcare. Try to be data-driven, because nothing is convincing so much as good data, and at the same time it helps to evaluate what you're doing. Are you on the right track or not? Political and community leadership is very, very important, and you have to outreach and ask people to help you and to join you. And last but not least, be bold as a city. Even if your national level is not helping, you can do a lot of things as a city. Try to make steps as much as you can. Being inclusive, working on anti-stigma, and try to reach to all target groups together. Thank you very much for your attention.
Thank you very much, Mrs. Mandelson. Moving on, we're running slightly late, so I appreciate the final panelists' patience. So we're moving on with Mr. Kroll, the Vice Minister of Health for Poland, who will be speaking about perspectives from Central and Eastern Europe. Thank you.
Thank you very much, especially for all organizing this event, a great event, and for the also organizers of the panel that is mixed between the political statements and such examples of the action which is already in place, give some kind of feeling that the goals can be reached much easier. I'm coming back to the level of the national level and also feeling the inspiration from the statement of the Commissioner. Thank you for these talks and voices. And also I'd like to share with you the message that the hope is among us, maybe not from this political session. The hope is much bigger from the previous session when the youngsters were having their own statements, and this young generation can introduce all of the strategies which we even not thinking. I came from Poland. Poland is a 38 million people country, and already it was mentioned from France, from Germany, and from other statements that most important is sustainability of action and financing to the goal with the decrease the epidemic of HIV, which is still global public health, one of the biggest threat. In Poland, we have lucky to be among the countries with the low prevalence. It is around 1,000 new HIV occurred every year. So in the 38 million country, we feel quite comfortable and looking for the key population which are infected each year is men who has a sex with men and also the injective drug users. And rest are much less significant, but in these two groups we are focusing our efforts the strongest. The first indication of HIV in Poland, it was not mentioned HIV in those times, is 1985, and from this period we establish a long-term of sustainable strategy for fight against HIV and AIDS. These strategies focus on the three points: the enabling environment, key policies, and establish legal framework. Second is the evidence-based systemic solution. That means that in HIV prevention and also in the treatment, we need data sources available across Europe and not only, an adequate allocation of financial resources. And up to a few years ago, our resources on the healthcare spending was not very significant, so that was the biggest threat in using this strategy. Nevertheless, we are proud to have the National AIDS Center, which was established in 1993, and coordinating on all activities, not only from the national level, collaborated with the Ministry of Health, Ministry of Justice, but also in the local level. That's why I'm hearing great experience from Amsterdam already heard, and such activities when the local is much more effective than from the in many cases from the national level, especially in the countries of the size of Poland. We established also the national program for preventing HIV infection and combating AIDS, which is adopted by the Council of Ministers. That happened in that was starting in 2001. So right now we've got sixth edition, which is connected with global strategy. Polish program is covering the years 2017, 2021, and this program has smoothly entered into force in order to guarantee the perfect sustainability of the process of combating HIV/AIDS. There's the governmental program, that means the sources are also available, so the financing is secured. It should be highlighted that participation of all key players ensured in its effective continuation through this program. And one of the biggest achievements, in my opinion, it is health policy program of the Ministry of Health, which called Antiretroviral treatment of people living with HIV in Poland. It continues the key integral part of national strategy. That means that all operation is guaranteed in the sustainable process. The program is consistent with the international recommendation and obligation taken on a global and regional level, including the Millennium Declaration, Declaration of Obligations, the protocols of the World Health Organization, recommendation of Council of Europe and Community Law of EU, and the rule of 3 ones. In Poland, free of charge, personalized ARV treatment is available to everybody, including mobile populations who fulfills medical conditions. That means that this treatment is guaranteed to all. The prophylaxis of a mother to child HIV transmission is one of the key elements of national strategy. In Poland, the financing and prevention of vertical transmission is one of the top priorities of Ministry of Health. All HIV positive pregnant women whose serological status is known are covered by the prophylaxis of the vertical transmission. And thanks to that implementation, we started in '89 with 23% of newborns infected, and this year, last year, we received the number 0. That's what we are happy about this program. And also national activities focus also for the people at risk of marginalization. And since 2001, the Penitentiary Service implements the same treatment program, also financed from the budget of Ministry of Health, according to all rules which are published in the international, let's say, organization. All prisoners, all inmates have full access, free of charge, and provide the same quality of and identical services which are offered outside of the penitentiary system. Add to that, since 2015, opioid substitution treatment has been made available to all those in need, also in the 155 penitentiary units in the country. Main goals of ARV program is increasing availability to modern ARV drugs and sustainable the access for all needed people, providing antiviral drugs necessary for the prevention of vertical infections, keeping on individual vaccination schedule for children born from HIV-infected mothers, providing antiviral drugs in post-exposure prophylaxis after accidental non-occupational exposures. Specialized diagnosis, purchase of the tests are also available. Since the very beginning, Poland has developed the sustainable financing for the antiviral treatment. Each year, the Ministry of Health allocates funds. This year, it is around 100 million euros. Also, according to prevention, there is the voluntary and free of charge HIV testing within anonymous purposes in the centers, specially developed to this diagnosis. It is free of charge. It's available to all, including the marginalized population. Over so many years, the system has undergone several modifications, and now it's adopted, in our opinion, to the changing epidemiological change. Let me conclude by saying that achieving operational sustainability in a resource-limited setting is feasible. However, HIV/AIDS service sustainability as such is a complex concept that would not be possible without political support of national governments and special dedicated programs. Taking this into account, as well as 30 years of Polish experience of combating HIV/AIDS in the most sustainable way possible, I would like to go on with supporting the process of implementation of the strategy to the end AIDS by 2030 around the world. We go hand in hand with all who take the fast-track approach in order to reach the 1990 treatment targets stipulated in the UN AIDS 2016-2021 strategy. I would like again to reaffirm our Polish commitment, active participation and support for the strategic ending AIDS epidemic 2013. Thank you very much for your attention.
Thank you very much, Mr. Kroll, for your perspectives on Central and Eastern Europe. So next we have Mr. Lete, a parliamentarian from Portugal, who will be discussing the leadership on HIV as part of the SDG implementation. Thank you.
Hello, and good afternoon. It's an honor to be here. Thank you for the invitation. And it's great to be in the fantastic city of Amsterdam. But as you can see, my hometown of Cascais, we're not as bad. We're not so bad off ourselves. I'm from Portugal, and in 1979, our National Health Service was founded. It's a universal health coverage system, and in '83, we had our first HIV infection diagnosed. As you all know, in 1996, triple therapy was presented at the AIDS conference in Vancouver, but despite having triple therapy that could control the infection, hard therapy was not enough to stop the rise of new infections in Portugal. In 2001, we decriminalized the use of drugs in our country, and what happened afterwards was extraordinary. As you can see here, policy sometimes can even be more powerful than drugs. With decriminalization of drug use, we were able to lower crime. We lowered drug-related imprisonments. We saw that the drug consumption in our country was lower than the rise was lower than in other EU countries, and we saw a rise in rehab success and dissuasion policies. And unlike what many people had said, we did not become a drug haven, nor did we become a center for drug tourism. In 2011, though, a major financial crisis hit Portugal, and we had the Troika intervention with the International Monetary Fund and the support of the European Commission and the European Central Bank. This was when I was personally elected into Parliament. Not the best time to get into politics. So I went from being in the hospital, working in the infectious diseases ward, into the corridors of power. And we were seeing in other countries where the financial crisis was hitting, we were seeing a rise of new HIV infections. So we had to address this straight on. And what we did, and I was the chair of the HIV All-Party Group, was to bring together civil society movements. We brought together scientists, healthcare workers, and industry. And we came up with a resolution that was approved unanimously by all parties from left to right in December 2011. So despite the hardships of a financial crisis, we continue the fight against HIV/AIDS, and we continue to see a decrease in number of new infections. Portugal was the 4th country to follow the START study and to have test and treat as part of our clinical guidelines. And in the meantime, in the middle of the financial crisis, we were one of the first countries in the world to give universal access, unconditional universal access to anyone diagnosed with hepatitis C. And by the end of this year, almost 20,000 people will have been cured, which means 1/3 of the estimated population will have been cured, which means we have saved lives. in 2017, I was lucky enough to be also deputy mayor and then councillor of the city of Cascais, which along with Lisbon and Porto, we joined the Fast Track Cities movement. And in my city, we changed the governance of the city, implementing a checklist based on the Sustainable Development Goals. No decision is made that does not go through this process. And we have a dashboard that keeps the city accountable. For each of the 17 goals, we know exactly where we are, and that guides our policies, and that guides where our money is going. So when we do our budgets, we really make sure that no one is left behind. And 2018, finally, the government has given access to PrEP in our country. So, with our collective efforts, despite the hardships of the past, we have hit 2 of the 3 90s. The first and the third 90 have been hit, but we're still lagging almost 4% behind on treatment on the second 90, and we still have over 50% late diagnosis. We have our challenges to be addressed still. And when we look globally, we see that in many parts of the world, we are lagging behind, or we're not progressing as fast as we should. We have the science, we have the knowledge, we know exactly what needs to be done to end this epidemic, but we have not been able to do so. And I believe that the main reason is due to lack of political will. We need politicians, governments and parliamentarians to come on board and to keep pushing forward. And because of that, we believe that we need to get parliamentarians involved into the discussion. Parliamentarians are the ones that actually approve budgets. They are the ones that change policies. They are at the interface between civil society and governments. But we know that many times parliamentarians, policymakers, are not included in these big discussions. We many times see governmental officials being called by multilateral organizations, but those that are directly elected by the people many times are excluded. And we have seen, and I believe that I've made the case, that parliamentarians can make a difference when it comes to ending this disease. And that's why we have founded Unite, a global network of parliamentarians focusing on ending HIV/AIDS, viral hepatitis, and other infectious diseases. We have through Unite, we are focusing on supporting members of parliament around the world, giving them the tools and the support that they need, from policy to advocacy, from science to best practice sharing, to communication skills, making sure that they can champion these causes and push the agenda forward. Because we need to bring everyone together, from governments to scientists, from parliamentarians to civil societies. We need to come together and reboot the activism within all of us so we can end what we have started. Because it is time for us to end AIDS. It's time to unite. Thank you very much.
Thank you very much. We could all learn a lot from Portugal. And last but not least, we have Ms. Raban, who's the coordinator for the EU Integrate Joint Action. Thank you.
Thank you, and thank you for staying on. So, as has been said already in this session, testing and achieving the first 90 is one of the keys to ending AIDS. We know what works in testing, and there are a number of good guidelines at both European and country level. We also know that these policies are not always implemented in practice, and that we are not always testing the right population groups at risk when designing testing programs. This slide shows how extensive testing is being performed in a country among blood donors and pregnant women, and with little effect, low positivity rates, while the population groups at risk are not reached. The EU Commission issued a policy on integration of disease areas, and I want to acknowledge the Commissioner for this visionary policy. One of the outcomes of this policy is the Integrate Joint Action, which has the overall objective to increase early diagnosis and linkage to prevention and care of HIV, viral hepatitis, TB, and STIs in EU member states. I have 3 points I would like to highlight on testing from the work of Integrate and related projects. My first point is that we need to work on the missed opportunities in the healthcare system to offer more tests. We are very good at this across Europe when it comes to testing pregnant women, with testing rates close to 100%, including in countries in the Eastern European region. But when it comes to implementing other proven effective strategies like routine testing offer when people present with indicator condition that could be indicative of an HIV infection, the test offer is often very low. Through the HIDES and the UpTest project, we have shown how support tools and training of staff has helped increase testing rates in healthcare settings. This shows the testing offer at baseline for patients presenting with hepatitis, pneumonia, and infectious mononucleosis-like illness. And this shows the change in testing after the introduction of support tools and training of staff. And this data is further explained by Anne Sullivan tomorrow in a poster presentation. So in Integrate, we will look at how to adapt available tools in HIV for hepatitis and other conditions. And the strategy of indicator condition-guided testing has already started an implementation phase in Romania, testing TB patients for HIV, and in Lithuania, focusing on STIs and HIV. My second point is the focus on testing in communities, as has already been raised by several speakers. We know there is a lack of resources and availability of testing kits, but we also know there are many regulatory barriers, which are not always the same for the different conditions. This is data from the Integrate baseline survey. As one example, lay provider testing is only allowed in 34% of countries in Europe compared to 64% in Africa. We know this is an effective strategy, and we need political support to change these regulatory frameworks. In the EU-funded projects, we can implement pilot activities that focus on some of these identified issues. However, these are not changed overnight, and some of the activities are possible to implement only because they are within the framework of European-wide projects. What we have recently implemented is a pilot spring testing week, supplementing the European testing week, which has been running since 2013, the last week of November, with around 600 participating organizations. The spring testing week was introduced as a way to focus more on hepatitis testing and combined testing, to use the momentum of this European initiative to support increased testing activities throughout the year. As you can see here, we have experienced an increase in combined testing for HIV and hepatitis over the years. And in the spring week, we also saw more focus on people who inject drugs and migrants, where the November week has to a larger extent had the MSM population as a key target group. My third and last point that I want to make is to again stress, as has been stressed before in this session, the importance of partnerships between EU and neighboring countries to leave no one behind. The HIV epidemic is rising with almost 80% of new diagnoses in the East, and this is the same for hepatitis, with over 60% of those affected living in Eastern Europe and Central Asia. Partnerships across borders are crucial to reverse this trend. One way to strengthen collaborations is this initiative of the HIV conferences, focusing on testing and linkage to care, to take place in Bucharest in January 2019. And we count on the continued support of the Commission and policy stakeholders in supporting what we can show have an impact. If you want to know more about Integrate, you can meet us in the EU booth in the exhibition hall. Thank you.
Okay, thank you very much. I know we are running way behind time. I'm just going to say thank you to the panel and thank you to the commissioners. I'm afraid we do not have time for questions. I have got a 12-word summary which goes something like this: protection, promotion and prevention, integration, inclusion and investment, data, focus and pragmatism, community and human rights. Thank you all very much for coming. Anna.